Hello guys, welcome back. In the previous two classes, we have discussed the basics and also we have seen the most important topic, that's the glomerular filtration rate. And in yesterday's class, we have discussed about the proximal convoluted tubule, related pathopoints as well as the pharmacology correlation. Okay, in yesterday's class, we have seen all these things. Now, in this today's class, let's continue with the topic of loop of Henle. Okay, proximal convoluted tubule is completed, the most active segment where most of the reabsorption is happening. So PCT is completed. Now let's go with the loop of Henle. Okay, so our topic for today is loop of Henle. Okay. Now, see, this loop of Henle is having how many parts? Right now, I am showing you the Bowman's capsule in a very simple way. Here is the afferent arteriole. Here you are having the glomerular capillaries, and this is the efferent arteriole. Okay, afferent arteriole. Here you are having glomerular capillaries, and this is the place where glomerular filtration is happening. Now, this part, the first part, is the proximal convoluted tubule, the most active segment. We have discussed about the proximal convoluted tubule. After proximal convoluted tubule, the next part in the nephron is the loop of Henle. See, right now I am showing you loop of Henle. Okay, this part, loop of Henle, and you are having a turn here. This turn is called hairpin turn, hairpin bend. Okay, now again there is this loop of Henle which is ascending. Important point is, see, there is this thick part. Okay, what I am trying to put here is that, see, this area which I am writing here is the descending limb. This is descending limb of loop of Henle. Okay, it's descending down into medulla. It's coming down into medulla. Okay, it's descending down. So this is descending limb. Now this area is the hairpin turn, and this segment, this part, okay, this part is the ascending limb of loop of Henle, but it is thin ascending part. Okay, so ascending limb of loop of Henle is having two parts again. So thin segment as well as a thick segment. Okay, thin segment as well as thick segment. Now after ascending limb of loop of Henle, next what you will have, guys? You will have other part which is called as distal convoluted tubule. Okay, distal convoluted tubule following collecting ducts as well as collecting tubules will be there. Now today in this class, our main concern is descending limb of loop of Henle. First we have to discuss about the descending limb of loop of Henle. Later we have to discuss about the ascending limb of loop of Henle. What I am telling you, ascending limb of loop of Henle is having two parts, thin ascending limb as well as thick ascending limb. Okay. Now let's start our topic, guys. See, right now I am just showing you descending limb of loop of Henle. Okay, descending limb. Here is the hairpin turn, and this is the ascending limb of loop of Henle. Now important point is, from proximal convoluted tubule, from the PCT above, the urinary filtrate is coming into the distal, the urinary filtrate is coming into the descending limb of loop of Henle, right? So what will be the concentration? 300 milliosmoles. 300 milliosmoles. I have said you, in the PCT, same amount of solutes will be reabsorbed and same amount of solvents will be reabsorbed. 70% of sodium chloride will be reabsorbed. So 70% of the water will be reabsorbed. So the urinary ultrafiltrate, the primary urine which is entering into the descending limb of loop of Henle is having isotonicity with the blood plasma. They are isoosmolar with the blood plasma. Okay. Now what's happening? Now this fluid or this urine is entering into descending limb of loop of Henle. Now what will happen here is, see, this area right now, this descending limb of loop of Henle, right from here, this descending limb of loop of Henle, first point is where it is present, sir. Where it is present? Is it present in the cortex, or is this area? The entire area, descending limb of loop of Henle and ascending limb of loop of Henle. The entire loop of Henle, is it present in cortex or is it present in medulla? It's present in medulla. See, Bowman's capsule, proximal convoluted tubule and even distal convoluted tubule. They are all present in cortex. But remember, the loop of Henle is present in the medulla of the kidney, not in the cortex of the kidney. The loop of Henle, they are going into the medulla of the kidney. So why I am stressing here is because, see, in the medulla there is hyperosmolarity. When you go deep down into the medulla, okay, when you are moving from cortex to medulla, what will happen, you know? In the cortex, the osmolarity is 300 only. But when you are going deep into the medulla, the osmolarity increases. So let me write it down here, guys. This is the entry. This is the entry point. Okay, entry. Now here the osmolarity is 300. Now what will happen if you are going deep down? It will become 400, 600, 800, 1000 and even 1200. So, in the deepest parts of medulla, what is the osmolarity? The osmolarity is even reaching up to 1200 milliosmoles. What is your blood osmolarity? The blood osmolarity or the plasma osmolarity is 300 milliosmoles. But in the kidney, there is a hyper concentrated environment. There is hyperosmolar medium is there. Now, what will happen? We all know from the basics, all the time fluid will move to hyperosmolarity. So see here, now fluid is entering here, the plasma is entering. Now here there are certain channels. Okay, there are certain channels, or I should say proteins, which are known as aqua, porin 1. Okay, aqua porin 1. Now these are the water channels. Outside there is hyper concentration. So much solutes are there. Just take. There is so much amount of sodium chloride here. Just sodium chloride is a solute, right? So wherever there is sodium chloride, there will be hyperosmolarity. So what's happening? Outside the nephrons, outside the loop of Henle, there is so much of sodium chloride, or so much hyperosmolarity is there. So what we should understand, wherever there is sodium, water will go towards the sodium, or wherever there are solutes, water will go towards the solutes. Okay, so what's happening now? All the water is going to come out. See here, the fluid is having 300, but outside there is 400 hyperosmolarity. Now when the fluid is going down, even the fluid, like, you know, is also becoming, the fluid is also equilibrating. Okay, now fluid is going out. Okay, water is getting reabsorbed. Only water is going. Important point. See, here also sodium is there, here also chlorine is there, calcium is there, magnesium is there. So many substances are there, so many solutes are there even in the loop of Henle. But what I am saying, that descending limb of loop of Henle is only permeable to water. It's allowing only water. So only water is being reabsorbed via which channels? Aquaporin 1 channels. So if only water is reabsorbed, means what happened to osmolarity in the loop of Henle? What happened to the osmolarity of urine? We are taking out only water. So the urine is getting concentrated now. Now why our urine will be concentrated? It's because of hyperosmolarity in the medulla. In the medulla there is so much of solute concentration, it will drag all the water towards itself. So only water is being reabsorbed in the descending limb of loop of Henle. So at the end part, at the hairpin turn, as only water is getting reabsorbed, when the fluid is going down in the descending limb of loop of Henle, even the fluid will get a concentration of 1200 milliosmoles. So in the hairpin turn, what is the concentration of urine? The concentration of urine will become 1200 milliosmoles. Okay, it's equilibrating. All the fluid is getting reabsorbed, but the solutes are not getting reabsorbed. So solutes are getting concentrated in the urine, making the urine hyperosmolar. Okay, later I will tell you, you can have a doubt, sir, why the medullary hyperosmolarity is kept on increasing, why there is this corticopapillary gradient. You can ask me, sir, when we are moving from cortex deep down into medulla, the hyperosmolarity is increasing. Why it is increasing, sir? Who is making the medullary hyperosmolarity? You can ask me, but that thing will be discussed in the later part. But as of now, important point is descending limb of loop of Henle only permeable to water. No solutes are getting reabsorbed. Second important point, descending limb of loop of Henle can I say something like this? Descending limb of loop of Henle is a concentrating segment or is it a diluting segment? Just tell me. Descending, I'm asking you guys, you should answer it. Descending limb of loop of Henle, is it a concentrating segment or is it a diluting segment? Now when the urine is going down in the descending limb of loop of Henle, urine is getting concentrated or urine is getting dilated? Come on guys, you should answer. I'm just checking the live chat. Maximum, someone is asking, maximum sodium reabsorption takes place where? Maximum sodium is going to be reabsorbed in the PCT. All the substances will be maximally reabsorbed in the PCT. Okay, there are a few exceptions that we will discuss in the end part, but maximum sodium reabsorption, maximum calcium reabsorption, 100% glucose, 100% amino acids, maximum phosphates are reabsorbed in the PCT only. There is no doubt. Okay, someone is asking. So, descending limb of loop of Henle, okay, DLOH means descending limb of loop of Henle. It's a concentrating segment. Okay, it's a concentrating segment for the urine. Now, what's happening? Urine, it is going into the ascending limb of loop of Henle. First, urine will go to the thin ascending part. Later, it will go to the thick ascending part. Okay, now I'm just showing you the thick ascending part. See, important point here is, here you will have the epithelial cells, right? Okay, all over the kidney, we are having the epithelial cells, this side, every side. Okay, you are having these epithelial cells. Now, important point is, see, urine is coming like this. When the urine is moving in the ascending limb of loop of Henle, what will happen? Important point to be noted here is, the ascending limb of loop of Henle, it's ascending, right? Ascending limb of loop of Henle is only permeable to, okay, it's only permeable to solutes, okay, not to water or not to solvents. Water cannot be reabsorbed in the ascending limb of loop of Henle, only solutes will be reabsorbed. So what does I mean by, see here on these epithelial cells, there are certain proteins, okay, there are certain proteins which are called as, now you should name it. First of all, I will tell you the function, you just name it. See, the urine is coming, the urine is ascending up. Now, when the urine is ascending up, this transporter or this protein will reabsorb the sodium. This transporter, same transporter will reabsorb potassium. The same transporter will again reabsorb 2 chlorine ions. Now, what I am saying is, in the ascending limb of loop of Henle, there is reabsorption of sodium, potassium as well as 2 chloride ions. Sodium, potassium, chloride are being reabsorbed in the ascending limb of loop of Henle. So, what is the name of this transporter? You just name it. What is the name of this transporter? The name of this transporter is, sir, sodium, potassium, 2 chlorine, symporter or antiporter. All the ions are moving in the same direction. So, symporter. Now, just have a recap. The ascending limb of loop of Henle is only permeable to reabsorption of solutes. Only solutes are getting reabsorbed. With the help of which transporter? Sodium, potassium, 2 chloride, symporter. Okay, sodium, potassium, 2 chloride, symporter. Now, in the exams, they will directly ask you this kind of questions. Sodium, potassium, 2 chloride, symporter is present in which part of the nephron? Is it present in the PCT or is it present in the descending limb of loop of Henle, ascending limb of loop of Henle, collecting ducts, collecting tubules? Now you know the answer. It is ascending limb of loop of Henle. Okay, you know it. Now, having discussed this, now please try to understand two important points. See, this sodium, potassium, 2 chloride symporter, what is it doing? It is reabsorbing sodium, potassium and 2 chloride ions from the urine, and these sodium, potassium, 2 chloride ions are going to enter into this sodium, this potassium and this 2 chloride ions. They are going to come where? They are coming in the medullary interstitium, sir. So, in the medullary interstitium, sodium is coming and getting deposited, potassium is coming and getting deposited, chlorine is coming and getting deposited. So, ions are getting deposited in the medulla, in the medullary interstitium. So, can we say medullary interstitium is getting hyper concentrated or medullary hyperosmolarity is created with the help of which transporter? Sir, medullary hyperosmolarity is created with the help of sodium potassium 2 chloride symporter. Now, in the beginning we have discussed, sir, the water is getting reabsorbed in the water is getting reabsorbed in the descending limb of loop of Henle. Now, why water is getting reabsorbed? Water is getting reabsorbed because in the medulla there is hyperosmolarity. Now tell me, how or who created the medullary hyperosmolarity? Medullary hyperosmolarity is created by sodium potassium 2 chloride symporter by a mechanism called as countercurrent multiplier system. Okay, countercurrent multiplier system is used in, you don't need to worry, I will explain what is countercurrent multiplier system, don't worry, but as of now just remember countercurrent. What does it mean by countercurrent? In the descending limb of loop of Henle, fluid is moving in this downward direction. In the ascending limb of loop of Henle, fluid is moving in the opposite direction. So this is countercurrent. Okay, fluid is moving in the opposite directions. So countercurrent multiplier system. So who is that multiplier system? This sodium potassium 2 chloride symporter. So with the help of sodium potassium 2 chloride system, medullary hyperosmolarity is generated. Completed. Okay, completed. Now, the second important point which you need to understand here is the ascending limb of loop of Henle. I am asking you a question. Ascending limb of loop of Henle, is it concentrating the urine or is it diluting the urine? You just tell me. Now, ascending limb of loop of Henle, is it concentrating the urine or is it diluting the urine? I am asking. Ascending limb is taking out the solutes from the urine. It's removing sodium, it's removing calcium, it's removing the chlorine from the ascending limb. So, my question is, ascending limb of loop of Henle, it's a diluting segment or concentrating segment? I'm just checking, guys. Come on. Naveen, Isha, yes. Isha, you are absolutely true. So, ascending limb is diluting segment for urine. Diluting segment for urine. Now, this is the place where examiners will try to play with you. Okay, this is the place where examiners will try to play with you. Sir, what do you mean by, if you ask me, see, you all guys know, sir, descending limb of loop of Henle, the first part here, this one. Descending limb of loop of Henle, yes, it is concentrating segment for urine, but descending limb of loop of Henle, from the descending limb of loop of Henle, water is getting reabsorbed. Okay, water is getting into the medullary interstitium or not? Water is coming into the medullary interstitium. So, if you are putting more and more water into medullary interstitium, what happened to medullary interstitium? All the solutes will be washed away, right? Washed away. So, try to understand the keywords. The descending limb of loop of Henle, what it is doing to medullary interstitium? It is diluting the medullary interstitium but concentrating the urine. Okay, so descending limb of loop of Henle, it is a diluting segment for medullary interstitium, but it is a concentrating segment. See, it's a concentrating segment for urine, but it's a diluting segment for medullary interstitium. In the same way, the ascending limb of loop of Henle, in the ascending limb of loop of Henle, the urine is getting diluted, no doubt. But in the same ascending limb of loop of Henle, with the help of sodium potassium 2 chloride symporter, more and more ions are getting deposited in the medullary interstitium. So, medullary interstitium is getting hyperosmolar or concentrated because of ascending limb of loop of Henle. So, write it down here. Ascending limb of loop of Henle, it's the concentrating segment for medullary interstitium. Okay, it's a concentrating segment for medullary interstitium. Okay, now after this, let's try to integrate with pharma. Okay, little bit pharma integration. You need to know certain drugs. Okay, you need to know certain drugs. Now, let's take up a clinical scenario. Imagine that there was this one patient who is coming to you with congestive heart failure. He is suffering with a condition called as congestive heart failure. Now, what does we mean by congestive heart failure? His heart is failing as a pump. So that's why he is having congestion. See, heart is not pumping. So there is heart failure. Okay, heart is not pumping in the sense it's not properly functioning. Okay, it's not able to meet the cardiac output or the demand by the body. It is very weak heart, not pumping properly. So what will happen? Blood is not moving in the forward direction. Blood is not going. So back pressures will be generated. Now my question is, from where your left ventricle is getting the blood? Sir, left ventricle is getting the blood from the lungs. In the lungs, oxygenation is happening. All the oxygenated blood will come to the left heart, that left area and left ventricle. Now what is the problem? Heart is not able to pump. If heart is not able to pump, what happened? Back pressures are generated. Now fluid is accumulating in the lungs. When the fluid is accumulating in the lungs, that is called as pulmonary edema. So that patient is going to have what? Dyspnea. Okay, fluid is accumulating in the lung. He can't breathe properly because there is fluid in the alveoli. Now he is coming to you. He is having a heart failure. Now how you have to treat this patient? Now he is having excessive fluids in his body. Now you have to take out that excessive fluids. Now how you will do that? Okay, so now based on the concept whatever we have studied, let's try to put it together. Okay, let's try to understand. Guys, what we have discussed? Normally fluid from the PCT is going to come down into the descending limb of loop of Henle. In the descending limb of loop of Henle, guys, please concentrate. Normally with the help of which transporter water is getting reabsorbed? Water will be reabsorbed with the help of aquaporin 1. Aquaporin 1. Now my question is, why water is getting reabsorbed? Sir, water is getting reabsorbed because in the medullary interstitium here, in the medullary interstitium, there is hyperosmolarity. The hyperosmolarity is the one responsible for the reabsorption. Now my question, second question. Who is creating the medullary hyperosmolarity? Sir, medullary hyperosmolarity is created with the help of sodium, potassium, 2-chlorine symporter. Okay. Now, what I am going to do, I am going to use a drug. I am going to use a drug called as loop diuretic. Okay, loop diuretic. Now, what this loop diuretic is going to do? Sir, loop diuretics will come and inhibit sodium potassium 2-chloride symporter. So, sodium potassium 2-chloride symporter is inhibited. If sodium potassium 2-chloride symporter is inhibited, what will happen? Do you know? There is no sodium reabsorption into the medulla. There is no potassium reabsorption. There is no chloride reabsorption. So, what is happening by inhibiting? Mark my words. By inhibiting sodium potassium 2-chloride symporter, the medullary osmolarity is getting decreased. You have decreased the medullary hyperosmolarity. Now, if medullary hyperosmolarity is decreased, means what will happen? There is no hyperosmolarity in the medulla, or the hyperosmolarity in the medulla is kept on getting decreased. So, water reabsorption will happen or not? Water reabsorption is not happening, sir. So, all the water which was supposed to be reabsorbed, the water which was supposed to be reabsorbed is now going out in the urine. It's now going out. Water is going out. Okay. So, all the water if you are taking out means the excessive water, that the extra water, whatever is there in the body, it is lost in the urine. So, more urination is going to be there in the person. So, more urination means that condition is called as diuresis. So, diuresis is going to happen. Diuresis means what? Excessive urination, more and more urination, polyuria. Okay, more urination. Or try to understand in a very simple way. If you don't understand, you can also understand it very simple way. Sir, what the loop diuretics are doing, I have already discussed with you. Loop diuretics, what is the mechanism of action? Sir, loop diuretics inhibit. Loop diuretic inhibit sodium, potassium, 2-chlorine symporter. So, sodium is not getting reabsorbed, potassium is not getting reabsorbed, chlorine is not getting reabsorbed. So, sodium, see here, sodium, potassium, 2-chloride, they are not getting reabsorbed. Where they are going? They are going in the urine. So, more sodium is going into the urine. If more sodium is going into the urine, water will follow the sodium. So, more water is also going into the urine, causing diuresis. So, more urination. You are taking excessive fluids out of the body. So, all the extra fluid, whatever is accumulated here or in any part of the body, you can take that excessive fluids with the help of a drug called Loop diuretics. And where loop diuretics are acting? Loop diuretics are acting in the ascending limb of loop of Henle. Now, can you name me any loop diuretic by any chance? You guys know any loop diuretics? You guys know any loop diuretics? I'm just seeing here. Any loop diuretics, guys? Do you know? Try to answer names. It will start with the letter F. Anyone? Come on. Come on, Isha. Saide. Yes, furosemide. Excellent, excellent, Saide. You are true. Furosemide. Bumetanide. Torsemide. Okay, torsemide. And ithacrenic acid. So furosemide, bumetanide, torsemide, ithacrenic acid, all these are the drugs which are acting on the ascending limb of loop of Henle, inhibiting the sodium potassium 2-chlorine sympathers. So sodium is lost in the urine, water follows the sodium. So excessive diuresis will happen. You can treat the congestive or you can treat the congestive heart failure, or you can also treat the pulmonary edema component. Okay, whatever the pulmonary edema he is suffering with, the dyspnea, you can treat it. It's also very good, right? See, heart is failing as a pump. Heart is not able to pump properly. Now, in these conditions, what you have to do, you have to increase the load on the heart or you have to decrease the load on the heart. Definitely you have to decrease the load on the heart. You are not supposed to put more and more blood into the heart. Okay, if you put more and more blood volume into the heart, it have to work more. So what you have to do as a good doctor, you have to decrease the load on the heart. How you can decrease the load on the heart? By decrease the blood volume. How you can decrease the blood volume? By taking out the excessive water from the blood. If you take out excessive water from the blood in the form of diuresis, automatically blood volumes are going to shrunk down. Blood volume will be decreased. So the amount of blood going to heart will decrease. Now heart will be doing less work. Okay, so that's how you can treat the congestive heart failure, by using drugs like loop diuretics. Okay, now after listening this, let's talk about one more important concept. Okay, one more important concept about the ascending limb of loop of Henle. Okay, now this is a very, very important concept which you should never ever forget. Okay, usually this is a favorite question for the examiners. Now see, normally calcium, magnesium reabsorption. Right now I am going to talk about the calcium magnesium reabsorption. Okay, now how calcium and magnesium are reabsorbed? See, right now whatever I am talking, this is absolutely physiologic. Okay, it's not something pathologic, it's absolutely physiologic. Okay, now see, what is the name of the transporter which is present over here in the ascending limb of loop of Henle? The name of the transporter is, sir, sodium, potassium, as well as 2-chlorine. Sodium, potassium, 2-chlorine sympathter. Normally, please look at this cell, sodium, potassium, the epithelial cell on the ascending limb of loop of Henle. On the ascending limb of loop of Henle, there are certain other channels also. Okay, there are certain other channels, or there are certain other pumps, I should say, because they are pumps. Now, what does I mean by pumps? They are using ATP. And do you know what this green color pump is doing? Now, this green color pump, it takes the sodium and it throws the sodium out. And from outside, it will try to bring the potassium in. Into the cell. So, what is the name of this green color channel? It is called as sodium, potassium, ATPase. Now, sodium, potassium, ATPase is present on the luminal membrane or basolateral membrane? Now, it is present on the basolateral membrane. On the luminal membrane, there is sodium, potassium, 2-chloride sympathter. Now, what I am trying to put into your mind is, see, whatever the sodium which is entering into the cell, now the same sodium is going out, is going into the interstitium with the help of sodium, potassium, ATPase. And whatever the chloride which have entered into the cell, even this chloride is going to go out with the help of certain channels. Okay, now let me show you here. There are channels through which even this chloride will also come into the interstitium. So sodium is coming out of the cell, even the chloride is coming out of the cell. But where comes the problem? Sir, the problem is with the potassium. Potassium is entering into the cell, but it is not able to go out. Okay, or there will be very little amount of potassium which will be leaking out with the help of potassium leaky channels. But right now, in order to frame the concept, let's try to understand like this. Sodium, whatever is coming into the cell, it's going out with the help of sodium potassium ATPase. And even whatever the chlorine is coming into the cell, it is going out with the help of chloride channels. Now, where comes the problem? Potassium is entering into the cell from both the sides. See, this potassium is coming via sodium potassium 2 chloride importer, and this potassium is coming into the cell via sodium potassium ATPase. Now, inside the cell, what is happening? More and more potassium is getting accumulated. If more and more potassium accumulating in the cell will become electrically positive. That's not something good here. Okay. Now, we all know cells will be having a negative charge. See, now in order to prevent this extra positivity inside the cell, do you know what will happen? Now, these cells are having certain channels. Guys, physiologically they are there. Okay. Now, these cells are having certain channels called as potassium leaky channels. Now, via this potassium leaky channels, whatever the potassium is accumulated inside the cell. Okay, I have taught you inside the cell potassium accumulation is happening. High amount of potassium is getting accumulated. Now, all this potassium again will leak back into the lumen. It's again coming back. Now you will get it out. Sir, first of all, why the potassium is entering and again why it is coming back? There is a reason. Okay, yes, potassium is going into the cell with the help of sodium, potassium, 2 chloride, important, no doubt. But again, the same potassium is again falling back into the lumen. Now, my question here is, so because of the leakage of potassium back into the lumen, now lumen, ascending limb of loop of Henle, the lumen in the ascending limb of loop of Henle, it will have which charge? Is it the ascending limb of loop of Henle, is it going to have a positive potential or negative potential? In the lumen I am asking. In the lumen, which potential is there? Come on guys. So because this potassium is coming again back into the ascending limb of loop of Henle, see potassium is coming here. So potassium means K plus. So because of the potassium leaking, now the ascending limb of loop of Henle, it is having which potential? Positive luminal potential. Very important MCQ. The ascending limb of loop of Henle is having positive lumen potential. Positive lumen potential. Okay. Now, what is the importance, sir? What is the importance? See, calcium, is it a positive charge or negative charge? Sir, calcium is a positive charge. It's a double positive, Ca2 plus, highly positive. And even magnesium, it's also positive charge. So, calcium and magnesium, whenever these divalent cations, okay, these are highly positively charged. Okay, not even a normal single charge, just like sodium. These are divalent cations with high positivity. Now, whenever they are coming into the ascending limb of loop of Henle, what will happen? Now, there is positive charge here also. Big positive charge is there. Even they are also having positive charge. So, positive charges will repel the positive charges. The positive lumen potential will repel the positive charge on the divalent cations. So, now this calcium and magnesium, the calcium and magnesium, can they move forward? Can they move forward? I am asking. Can they move forward in the ascending limb of loop of Henle? Is it possible? It's not possible. So, what happens? The calcium and magnesium is going to move back. So, with the help of a paracellular transport, let me show you here in a better way so that it will be easy for you. So, here are the cells. Okay, here are the cells. Now, the calcium and magnesium from in between the cells. Okay, in between the cells, there are small gaps. Through those small gaps, calcium and magnesium are reabsorbed back into medullary interstitium. Okay, now what is the significance of positive luminal potential in the ascending limb of loop of Henle? The positive luminal potential will help in reabsorption of calcium and magnesium. So from now, just tell me, the direct question which was asked many times, magnesium reabsorption happens in, this was the favorite question for the examiners, magnesium reabsorption happens in, calcium is mainly reabsorbed in the PCT, but magnesium important, magnesium reabsorption mainly happens in the ascending limb of loop of Henle due to positive luminal potential because of the potassium. Okay guys, is the concept clear? Is the concept clear? Guys, if the concept is clear, I will integrate it with pharma. Okay, I will integrate it with pharma. Very important concepts are there. Pharma correlation. Is the concept clear, guys? Now, let's talk about pharma correlation. How to integrate it with pharma. See, again I am drawing descending limb of loop of Henle and ascending limb of loop of Henle. Now, the drugs which I am using here in this condition is loop diuretic. Okay, I am using loop diuretic. Example is furosemide. Okay, furosemide. I am using a drug called as furosemide. Now, we all know this furosemide, what it is going to do? Sir, furosemide, it is inhibiting sodium, potassium, 2-chloride symporter. Now, this furosemide, it will come and inhibit sodium, potassium, 2-chloride symporter. Now, tell me what will happen. If sodium, potassium, 2-chloride symporter is inhibited by furosemide, now potassium is not entering into the cell. First of all, the potassium is not at all entering into the cell. If potassium is not entering into the cell, will it leak out? Will potassium leak out of the cell? Definitely not possible. Okay, potassium is not entering, so definitely it is not going to leak back. Now what will happen? If potassium is not leaking back, my question, if potassium is not leaking back, will the lumen have positive potential? The positivity, the ascending limb of loop of Henle, will it have a positive luminal potential? Is it possible now? No, it's not possible. The lumen is not having this positive potential. Now if the positive potential, if it's not there, what will happen? Can calcium reabsorption and magnesium reabsorption, can it happen? No. The calcium and magnesium which was supposed to be reabsorbed in ascending limb of loop of Henle due to positive luminal potential is not going to happen now because we are using loop diuretics. Loop diuretics inhibit sodium, potassium, 2-chloride symporter. Now what will happen? Now all this calcium and all this magnesium is going to leak back into the urine, sir. Okay, now tell me, based on this concept, if you use drugs like loop diuretics, now will they increase the calcium excretion or will they decrease the calcium excretion? This is the question. I want you to answer. Isha, Ranjan, Harshita, you just try to answer it. PK, Ranjan Kumar, try to answer. If you use drugs like loop diuretics, furosemide, ethacrenic acid, torsemide, if you use such kind of drugs, what happened to calcium reabsorption? Calcium reabsorption decreases, calcium excretion increases. So loop diuretics loop out, remember it like this, loops out calcium from the body. It will loops out the calcium from the body. So it can be used in the conditions like, so if loop diuretics, they are taking the calcium out of the body, it's taking the calcium out of the body. Now based on this concept, you just tell me, can I use this loop diuretics for the treatment of hypercalcemia? Imagine if a person is suffering with hypercalcemia. Imagine I am suffering with hypercalcemia. What is a good doctor you should do? You should have to bring down the calcium levels. How you can bring down the calcium levels? With the help of drugs like loop diuretics. Loop diuretics take out the extra calcium from the body, decreases the calcium levels in the plasma. So used in treatment of hypercalcemia. Okay, hypercalcemia, treatment of hypercalcemia. But one of the side effects of this loop diuretic is what? Sir, when you use loop diuretics, what is happening? More and more calcium. See, let me show you here. You need to understand this. These are the kidneys. Okay, these are the kidneys. Now, here are the renal pyramids. Okay, renal pyramids with the renal cortex and renal medulla is there. Okay, now when you use drugs like loop diuretics. Okay, whenever you use the drugs like loop diuretics, what will happen? Extra amount of calcium is coming to this area or not? Excessive amount of calcium is getting lost from the body. So excessive amount of calcium is coming into the renal pelvis. Now you are putting more and more calcium in the renal pelvis. Now what will happen? This calcium can precipitate. Okay, it can precipitate and it can form calcium stones. So loop diuretics, are they causing kidney stones or not? Yes, they are causing kidney stones. So the condition is called as nephrolithiasis. Okay, so they can cause nephrolithiasis. They are putting more and more calcium into the renal pelvis, so that calcium can precipitate and can form the kidney stones. So these are some important concepts which you need to know regarding ascending limb of loop of Henle. We have discussed about the descending limb of loop of Henle, and we have also discussed about the descending limb of loop of Henle, and we have discussed about the ascending limb of loop of Henle. Now let's continue with the topic of distal convoluted tubules, guys. If you have any doubt, you can ask me. If you have any doubt, you can ask me. Before going to distal convoluted tubule, I just want you to know one more thing also, which is a pathocorrelation. Okay, a pathocorrelation. Now, normally, if you use loop, nephrolithiasis means, nephro means kidney, lithiasis, lithos means stone, nephrolithiasis means kidney stones. That's the calcium stones are forming in the kidney. That's known as nephrolithiasis. Okay. Now, if you use drugs like loop diuretics, which transporter is inhibited? Just tell me. Sir, sodium, potassium, 2-chloride, symporter. Sodium, potassium, 2-chloride symporter is inhibited. Now, why we are discussing this is because there was this one pathological condition. Okay, but there is on this disease known as Bartter syndrome. Bartter syndrome. Now, what is this Bartter syndrome, sir? Bartter syndrome means by birth itself. Now, the patient is having mutation of sodium, potassium, 2-chloride, symporter. This is a mutation. Okay. Okay, it's a mutation. Now, in Bartter syndrome, what is the problem? Where exactly is the problem? Sodium, potassium, 2-chloride symporter is not functioning. If you take loop diuretics, which transporter is not going to function? Sodium, potassium, 2-chloride symporter is not going to function. So can I say in both the conditions, same transporter is getting affected? So I can clearly say loop diuretic symptoms and Bartter syndrome symptoms will be exactly the same. So loop diuretics usage resembles Bartter syndrome. Why? Because in both the conditions, same transporter is affected. Sodium, potassium, 2-chloride symporter is affected. Okay, guys? No, furosemide. See, furosemide side effect is, loop diuretic side effect is kidney stones. Okay, not for the treatment of kidney stones. If you use loop diuretics loop out the calcium from the body. Loop diuretics taking all the calcium and putting more and more calcium here. Okay, more and more calcium in the urine. Now in the urine, see, the urine is going to go through the renal pelvis. Do you know what will happen? Now all the calcium, there is excessive amount of calcium is there in the urine. So this excessive calcium which is there in the urine, it will precipitate and it will form the kidney stones. What I am saying is loop diuretics, if you use loop diuretics, there is the risk of getting kidney stones. Loop diuretics decreases the blood calcium levels. Okay. I hope Saitej, your doubt is cleared. Sir, at what consistent dose of loop diuretics there is high probability of nephrolithiasis? Can it cause osteoporosis on chronic therapy? See, the doses, that and all you will discuss in internal medicine. Whenever you guys will study internal medicine in your 5th year, then you will get all these doses. See, at this level in physiology, doses are not that important. Okay, you will study the appropriate doses. Here I am not the one who should teach you the amount of doses. The doses component will be discussed in the internal medicine things. Okay. Now, here I just want you to know one more important point, which is called as counter current exchanger. Guys, previously I have taught you one important terminology which is called as counter current multiplier. So what is counter current multiplier? Counter current multiplier system with the help of sodium potassium 2 chloride symporter helps in generation of medullary hyperosmolarity. The medullary hyperosmolarity is generated with the help of sodium potassium 2 chloride symporter. That entire system is called as counter current multiplier. But right now I am talking about something called as counter current exchanger. Now what is this counter current exchanger? Very simple. The concept is, see, here is your descending limb of loop of Henle, hairpin turn, and ascending limb of loop of Henle. Now let me draw one more. First of all, let me draw this in a different color. Now I am drawing you descending limb of loop of Henle, hairpin turn, and ascending limb of loop of Henle. Now I am drawing one more structure which is nothing but a blood vessel. Okay, which is nothing but a blood vessel. Normally, see, the urine. Okay, urine is moving like this. Okay, so via descending limb of loop of Henle, via hairpin turn, and via ascending limb of loop of Henle, the urine is moving like this. Now, what is the important event in the descending limb of loop of Henle? I have discussed with you, in the descending limb of loop of Henle, sir, water is getting reabsorbed. See, water is getting reabsorbed. Now, my question is, if water is getting reabsorbed, where this water is going, just tell me. Sir, water is going first into medullary interstitium. Now, if you are putting this water into medullary interstitium, what this water will do? This water will wash away the solutes, so that medullary hyperosmolarity will be affected. You are keeping more and more water, right? This water will simply wash away the solutes. So, medullary hyperosmolarity will be destroyed or will be affected. Is that something good? Are you supposed to have water in the kidneys? Are you supposed to have water in the medullary interstitium? No. Water was not supposed to be there in the medullary interstitium. Then where do you want this water? The water which is reabsorbed now, it should have to again go back into the systemic circulation. So all this water will again jump back into this blood vessel. Okay, there was this one blood vessel, like, blood flow is like this. Okay, the blood flow is like this. Now this blood will catch up this extra water and it will take the water again back into the systemic circulation. So this is called as counter current. Why we are calling it as counter current? Why? Because see, in the blood vessel, the movement of blood is towards up, but in the nephron, the movement of fluid is towards downside. So opposite currents. So counter current exchanging is happening. Water is getting exchanged. It's taking all the water and it is going back. So this is called as counter current exchanger. Can you name me what is the name of this blood vessel? Can anyone name me what is the name of this blood vessel? Sir, what is the name of this blood vessel? The name of this blood vessel is vasa recta. Okay, vasa recta. So vasa recta is helping in what? The vasa recta will collect all that extra water. It will take that extra water again going back into the systemic circulation, not letting the medullary osmolarity to be affected. Okay, so counter current exchanger system is with the help of this counter current exchange is with the help of which blood vessel? Vasa recta. So vasa recta is helping in counter current exchange. Sodium potassium 2 chloride is helping in counter current multiplier system for the generation of medullary hyperosmolarity. Now Saitej, you are asking about nephrolithiasis. I have taught you. It's very simple. Whenever you use loop diuretics, remember loop diuretics loops out the calcium from the body. Loop diuretics loops out the calcium, which means loop out means like removing the calcium from the body. Loop diuretics, what they are doing? They are taking all the calcium from the body. Okay, normally calcium and magnesium, I have taught you, calcium and magnesium, they are supposed to be reabsorbed in the ascending limb of loop of Henle. In the ascending limb of loop of Henle, calcium and magnesium are reabsorbed. But whenever you use loop diuretics, the positive luminal potential is lost. So calcium and magnesium are going out in the urine. So you are putting more and more calcium. You are putting more and more calcium into the urine. So in the urine, what will happen? In the urine, the calcium molecules will come together. All the calcium molecules will come together. They will precipitate and form kidney stones. So whenever you use loop diuretics, they will cause calciuresis. Calcium is lost in the urine. So calcium will bind and they will form kidney stones. Okay. So side effect of loop diuretics is kidney stones. So all the important points which we have discussed are very, very important. So descending loop, water is reabsorbed. This can reduce medullary hyperosmolarity. Yeah, that's what I'm saying. No, whatever the water is getting reabsorbed, all this water, where it is going? First the water is getting into medullary interstitium. Now this medullary interstitium can be affected. So this water will be again going back into the vasa recta. Vasa recta will collect all that water. It will take the water and it will go away. So vasa recta is helping in maintenance. Okay, it's helping in maintenance of medullary hyperosmolarity. Okay, now guys, let's take a break of 5 minutes. After the break, let's continue with the distal convoluted tubule collecting ducts. Okay, later we will discuss about the distal convoluted tubule and collecting ducts. Thank you. If you have Okay guys, now let's continue with the distal convoluted tubule. Okay, now let's continue with the topic of DCT, which is called as distal convoluted tubule. Now let's draw it a very simple diagram. Okay, distal convoluted tubule. This is ascending limb of loop of Henle. Okay, here this is the ascending limb of loop of Henle. Here is your this turn which I am highlighting with right now. This area is distal convoluted tubule. Okay, DCT. Now, what are the important points which you need to know? So, this distal convoluted tubule is also divided into two parts: early DCT, late DCT. Okay, I'm just dividing it into two parts: early DCT and late DCT. Okay, late distal convoluted tubule. Now, in the early DCT, there is this one important area. On the early DCT, there are these important cells which are very dark in color. Now, I'm saying you these dark color cells, they will produce a substance called as adenosine, and whenever they are whenever necessary, they will activate juxtaglomerular cells. Can you name me these cells? What are the name of these cells? These cells which are releasing the adenosine, which are present in the early part of distal convoluted tubule. Can you name me these cells? They start with the letter M. They are called as macula densa. In yesterday's class we have discussed. So repeatedly asked question in your exam. Macula densa is present in which part of the nephron? PCT, loop of Henle, DCT, collecting ducts, collecting tubules. They are present in early DCT, early distal convoluted tubule. Okay, now after seeing this, let's talk about some important points about the distal convoluted tubule. Let me draw it here. See, I'm just showing you the distal convoluted tubule here. Okay. Now, what is happening in the distal convoluted tubule? This DCT. Now, see, there are this one important cell. Okay, right now I'm mainly talking about the late DCT, late DCT. Okay, this was the epithelial cell. Epithelial cell. Now, there are four important transporters which are present on this epithelial cell. Now, see, the first transporter which you need to know, this transporter, the transporter number 1. This transporter is called as, or before telling the name, you just see the function. It is reabsorbing sodium and it is also reabsorbing chlorine into the cell. So, reabsorption of sodium and chloride is happening even in the DCT with the help of this transporter. So, the name of this transporter is the first transporter, sodium chloride symporter. Okay, sodium chloride symporter. Now, the second type of transporter which is also present on the luminal surface. Now, this transporter, what it is doing is, it's reabsorbing calcium into the cell, calcium reabsorption. The name of this transporter is TRPV5, transient receptor potential vanilloid channel 5. Transient receptor potential vanilloid channel 5. Later I will write, don't worry. TRPV5 channel which is present on the luminal surface on the DCT epithelial cells, helps in the reabsorption of calcium. The second type of transporter we have discussed. Now, the third important transporter which is present here on the basolateral membrane, what it is doing? It is throwing the calcium out, and it will bring sodium into the cell. Bringing the sodium into the cell, sending the calcium out of the cell. Okay, so God have made these cells in such a way, the God have kept all this transporter, the nature have kept all this, the nature designed these cells in such a way, on their basolateral membranes, there is this one transporter which is there is bringing the sodium into the cell and sending the calcium out of the cell. So, what is the name of this channel? This channel is called as sodium calcium exchanger. Okay, sodium calcium exchanger. Now, the fourth transporter which is again present on the basolateral membrane, what it is doing? It will throw the sodium out of the cell. Brings potassium into the cell, and with the help of breaking down of ATP, it uses ATP. So, can you name me what is the pump? What is the name of this pump? Sodium, potassium, ATPase. Now, The kind of questions that will be coming in your exam is, all of the following transporters are present in the DCT epithelial cells except, so you know 4 type of transporters. First type of importer is sodium chloride importer, TRPV5 calcium channel, sodium calcium exchanger, as well as sodium potassium ATPase. Okay, you know 4 different types of transporters. Now, after seeing 4 different type of transporters, let's try to integrate it with pharma. Okay, now let's try to integrate it with pharma. Sir, there are certain drugs which will come and inhibit this channel. Okay, if you give a drug, see, imagine that this was X was a drug. Now this X drug will come and inhibit this channel. So what's happening? Sodium which was supposed to be reabsorbed, is now not getting reabsorbed. Now all that sodium is getting lost in the urine. So sodium goes, water follows, causing diuresis. So again, one more kind of diuretic drugs. Can you name me what is the name of this diuretic? The diuretic which is coming and inhibiting the sodium chloride importers. Can you name me? Yes, I will try to go a little slow. Can you tell me what is the diuretic which will come and inhibit sodium chloride importer channels? What is the name of those kind of diuretics? Loop diuretics already we have discussed. Furosemide, torsemide, bumetanide, ethacrenic acid, all these are the loop diuretics. Now what I am saying is, sodium chloride importer is inhibited by which kind of drugs? If you know, just tell me. It starts with the letter T, thiazides. So thiazides are the drugs. Okay, so thiazides are the diuretics which will come and inhibit sodium chloride importer. Now, why thiazides are called as diuretics is because sodium reabsorption is not happening. Sodium is lost in the urine. So all the water will follow the urine. Into the urine, causes the diuresis. Okay. Now, if you use thiazide diuretics, what happened to calcium reabsorption? This is a very important pathology concept. Thiazides and calcium. Now, what is the relationship between thiazides and calcium? I have already taught you. Loop diuretics, if you use loop diuretics, calcium is lost from the body. Thiazides loop diuretics loop out the calcium from the body. If you use furosemide, bumetanide, they will take out the calcium from the body. Already we have discussed this. Now, what is the relationship between thiazides and calcium? What is the relationship? See, you just think logically and tell me. Now, whenever you use thiazides, what will happen? Please concentrate here. Here is the sodium chloride importer, and here is the calcium channel. Okay, calcium channel. Here is sodium, potassium, ATPase, and one more channel, that is the sodium calcium exchanger is there. Okay, now see, whenever you use these thiazide diuretics, what will happen? Thiazide diuretics will inhibit sodium chloride importers. Now, sodium is not entering into the cell. First of all, sodium is not entering into the cell. Normally, sodium is coming into the cell via 2 routes. Please concentrate. Normally, sodium is coming into the cell with the help of sodium chloride importer, and sodium is coming into the cell with the help of sodium calcium exchanger. There are 2 ways by which sodium is entering into the cell. But if you give thiazide diuretics, sodium is not coming into the cell. So what happened to intracellular levels of sodium? The intracellular levels of sodium is going to go down, sir. The intracellular levels of sodium is falling down. It's falling down. Now, if the intracellular sodium levels are going down, that will definitely affect the cellular functions. Okay, that will definitely damage the cells, affect the cellular metabolism. So, if one way is blocked, if you block this one way, what should happen? The other way need to be activated. Now the sodium calcium exchanger, it will work more, it will work more. Okay, it will work more to bring more sodium into the cell. It will bring more sodium into the cell. It's working more and more. Now, in order to bring sodium into the cell, it have to throw calcium out into the blood. It have to send the calcium back into the blood. Now, from where it can get the calcium? It can get the calcium via this route. Okay, now it have to get the calcium. So again, this calcium channel is now activated. It's now activated. Okay, now the sodium calcium exchanger is working more. It will bring more sodium into the cell. In order to bring more sodium into the cell, it have to throw more calcium out of the cell. Now from where it can get the calcium? It can get the calcium from here. So what I am trying to put into your mind is very, very important. Whenever you use thiazide diuretics, calcium reabsorption will be increased. More and more calcium will be reabsorbed into the cell. Okay, so thiazides will increase the calcium reabsorption or decrease the calcium reabsorption. See, I have already taught you loop diuretics. Okay, loop diuretics decreases the calcium reabsorption. Okay, decreases the calcium reabsorption. But thiazide diuretic, okay, thiazide diuretics, what they will do? Increase the calcium reabsorption, increase the calcium reabsorption. Now, so where I can use this thiazide diuretics? Where I can use this thiazide diuretics? So if a person is suffering with the nephrolithiasis, see now, if a person is suffering with the nephrolithiasis, I can use drugs like thiazide diuretics. Why? Because what thiazide diuretics are doing? Thiazide diuretics decreases the, see, thiazide diuretics decreases the calcium excretion. Okay, calcium is not going into the urine. If calcium goes into the urine, in the urine calcium will precipitate and forms the stones. But what thiazide diuretics are doing? Thiazide diuretics, if you use thiazide diuretics, nephrons will reabsorb more and more calcium. If more calcium is getting reabsorbed, what happened to urinary concentration of calcium? Urinary concentration of calcium will be decreased. So the incidence of stone formation is going to be decreased. So thiazide diuretics can be used in the treatment of patient who is going to have recurrent nephrolithiasis. Okay, the patient is having recurrent again and again. If the patient is developing the stones, in that person, you can use drugs like thiazide diuretics. Okay. Yes, even bone weakness also, whenever you use thiazide, see, the thiazide diuretics for bone weakness, see, theoretically speaking, okay, theoretically speaking, what we can say is, sir, thiazide diuretics will increase the calcium reabsorption. You will think like this, okay, Isha, you might be thinking like, sir, conceptually, thiazide diuretics will increase the calcium reabsorption. This calcium will go back again into the blood, and this calcium can be used for the, like, bone formation. So theoretically we can say, but the practical implication is absolutely different. Okay, say the amount of calcium reabsorbed with the help of thiazide diuretics is not enough for treating the bone problems. It's not that much enough. Usually if you want to treat bone related issues, you have to give calcium supplements. Okay, so thiazide diuretics treating bone pain, that's not going to be a very much practical thing. Okay, if a person is having osteoporosis, bone weakness, bone mineral density is decreasing, there are certain other group of drugs which will be treating osteoporosis, like the drugs which are called as teriparatide, calcium supplements, and the drug of choices are alendronate, zoledronate, pamidronate. Okay, there are drugs called as bisphosphonates. Okay, there are drugs called as bisphosphonates, which are the drug of choice for treating osteoporosis. That's a totally different topic we will discuss in the endocrinology. But here I have cleared your doubt. This much calcium reabsorption is not enough. Okay, thiazide diuretics, whatever the calcium reabsorption is happening, that's not enough for treating the bone problems. Okay. Now, after this, what we will discuss is that See, again I am showing you distal convoluted tubule, DCT. Here is the epithelial cell with the 4 types of transporters. I have taught you 4 different types of transporter: calcium transporter, sodium chloride importer, okay, sodium calcium exchanger, as well as sodium potassium ATPase. I have discussed with you. Now, I want to integrate it with endocrinology. Sir, normally, whenever your blood calcium levels are going down, okay, whenever your blood calcium levels are going down, what is that condition? You will suffer with hypocalcemia. You will suffer with a condition called as hypocalcemia. Now, what your body was supposed to do? In the conditions of hypocalcemia, are you supposed to lose any calcium from the body? No. In the conditions of hypocalcemia, see, if there is hypocalcemia in my body, definitely I am going to have spasm of the muscles. I will be having spasms called as a tetany. So, in the conditions of hypocalcemia, what my kidney should do? My kidneys should reabsorb as much calcium as possible. Okay. So, how it will happen? See, hypocalcemia, whenever there is hypocalcemia in your body, there is this one organ which all the time looks at the blood calcium levels. See, if blood calcium levels are going down, this one body organ will be activated. Can you name me what is that body organ? Or it's not an organ, I should say, it's a gland. Okay, there was this one gland in your body which is all the time looking at the blood calcium levels. If blood calcium levels, if they are going down, this gland will be activated and tries to increase the blood calcium levels. Can you name me what is that gland? It's parathyroid glands. So remember, for your entire life, whenever there is hypocalcemia in your body, parathyroid glands will be activated. Parathyroid glands. There are 4 parathyroid glands. Now, what these parathyroid glands are doing, do you know? They will secrete a hormone called as parathyroid hormone or parathyroid hormone. Now, do you know what this parathyroid hormone is going to do? Now, this parathyroid hormone, it will activate this channel. Okay. Now, what is this channel? This channel is increasing the calcium reabsorption. What is that? TRPV5. So, transient receptor potential vanillite channel 5, it is going to be working more and more. Now, it works more and more. What will happen? More and more calcium is going to be reabsorbed. There will be more calcium reabsorption. Okay, more and more calcium will be reabsorbed. Is that good or not in this condition? Yes, already the patient is suffering with hypocalcemia. You are not supposed to lose any calcium in the urine. So, more calcium will be reabsorbed. So, parathyroid hormone, can I say parathyroid hormone increases the calcium reabsorption in the kidneys? Is that a true statement? Absolutely true statement. So, note, parathyroid hormone increases the calcium reabsorption. Okay, increases the calcium reabsorption. Okay, and bring back the calcium levels to normal. Okay, now after this, let's talk one more concept. Guys, you should tell me. See, this is the epithelial cell. Here is the epithelial cell. Now, here is the channel. These are the channels, 4 channels which are present in the distal convoluted tubular epithelial cell. Now, what is this channel? Try to answer it. This is sodium chloride symporter, sodium chloride symporter. Now, I am asking you, what is the drug which will come and inhibit the sodium chloride symporter? The sodium chloride symporter is inhibited by which drugs? Yes, you already know, thiazides. So, thiazides are inhibiting sodium chloride symporters. Okay. Now, see, we have already studied that loop diuretics inhibit sodium potassium 2-chlorine symporter. But there was this one syndrome which is just resembling sodium potassium which is just resembling the usage of loop diuretics. Can you name that syndrome? Bartter syndrome. So, Bartter syndrome, it looks like or it resembles loop diuretic overusage. Now, what I am saying is thiazides inhibit sodium chloride symporter. In the same way, there was this one disease called as Gittelmann's syndrome. There was this one syndrome called as Gittelmann syndrome. In this Gittelmann syndrome, by birth itself, the sodium chloride symporter is mutated. So, in both the conditions, tell me, in both the conditions, sir, the same transporter is affected. So both the condition will resemble one another or not. So usage of the thiazide diuretics and Gitelman syndrome, in both the conditions you will have similar features. So thiazide diuretic usage, will resembles Gitelman syndrome, or Gitelman syndrome resembles thiazide diuretic usage. Okay, so this is a very important point. Direct question is, Gitelman syndrome resembles which diuretic usage? It resembles loop diuretic usage? No, resembles thiazide diuretic over usage. Okay. Guys, shall we continue further? Shall we continue further? DCT is also completed. Important points which was supposed to be known, all those important points are completed. Now, in a nephron, we have seen the filtration, we have seen the proximal convoluted tubule, we have seen descending limb of loop of Henle, hairpin turn, ascending limb of loop of Henle. Also, we have discussed about the distal convoluted tubule. Now, we are supposed to discuss about the collecting ducts. Okay, we have to discuss about the collecting ducts. Okay, collecting ducts. Okay, now important point is, how many collecting ducts are there? This is not that important. If you want to know, there are two collecting ducts. There was this one part of collecting duct which is present in the cortex. So cortical collecting duct as well as medullary collecting duct. So two parts are there, sir. Cortical collecting duct, medullary collecting duct. Not that important. But important point is, see, I am just showing you the collecting duct. Okay, in a simple way. So here is the collecting duct. Now on this collecting duct, how many types of cells are there? How many types of cells are there on this collecting duct? Can you name me? There are two important cells which are there on the collecting ducts. Can you name me these two important types of cells? First cell type is called as principal cells, and second type of cells are called as intercalated cells. The first type of cells are principal cells, second type of cells are intercalated cells. Two different types of cells. Okay, now, okay sir, collecting duct have two different types of cells. Now, important point which you need to know is, sir, on the cells, on the collecting duct, two important hormones will be acting. Two hormones. So guys, from here you need to be very much attentive. Why? Because whatever we are discussing here will be also coming, or like integrating endocrinology. Okay, we are integrating it with hormones. There are two important hormones which will come and act on these collecting ducts. What are the two important hormones? So the two important hormones, first hormone is aldosterone. Sir, aldosterone will come and act on collecting ducts. Second important hormone is antidiuretic hormone, also called as vasopressin. Sir, antidiuretic hormone and vasopressin will also act on this collecting ducts. What does I mean by C? Important point is, this aldosterone is there? No. First of all, let me start with the aldosterone. Aldosterone. First question, sir, from where aldosterone is produced? Can you tell me? Aldosterone, I am telling you, aldosterone is acting on the collecting duct. Why it is acting, how it will act, what are the functions, we will discuss in a minute. But aldosterone is produced from where? Sir, aldosterone is produced from a gland called as adrenal gland. Okay, on the kidneys, we all know, so if you take this as a kidney, on the kidneys, okay, on the superior pole of kidneys, you are having this adrenal gland. Now this adrenal gland is mainly divided into two regions. The first region which is present in the center, the central region is called as medulla. Okay, and the outer region is called as cortex. Now the cortex was further divided into three regions. Just remember it like GFR. GFR means the outermost region is called as zona, or the outermost zone is called as zona glomerulosa. The The middle region, F for zona fasciculata, and the innermost region is called as zona reticularis. Okay. Now, this aldosterone is coming from where? Sir, aldosterone, it is coming from zona glomerulosa. Zona glomerulosa is producing aldosterone. Now, what is the function of aldosterone? See, we all know aldosterone is an example of mineralocorticoid. It's an example of mineralocorticoid. What does we mean by mineralocorticoid? It helps in mineral metabolism. There is some important function with the minerals. Now, what is that important mineral? Sodium, sir. So, this aldosterone is helping in sodium reabsorption. Okay. So, mineralocorticoids like aldosterone helps in sodium reabsorption. How that will happen? How that will happen? Now, let's see one by one. Again, let's come back to our concept. This is our collecting duct. Collecting duct. On the collecting duct, how many types of cells are there? The first type of cell is called as principal cell. Okay, it's principal cell. And what is the second type of cell? It is called as intercalated cell. Okay, intercalated cell. Now we are having aldosterone. Aldosterone. Now, aldosterone is there. Now, what this aldosterone will do? Sir, aldosterone, it will come and acting on which cell? Now tell me. Aldosterone will act on principal cell or intercalated cell? Remember, aldosterone can act on both the cells. Aldosterone will act on collecting ducts. It will act on principal cell as well as it will act on intercalated cells also. Okay. Now, aldosterone, it will cross the cell membrane. It will cross the cell membrane. Why? Because it's an example of a steroid. Aldosterone, sterone, it's a steroid made out of cholesterol. It's made out of a fat. So, it will cross the lipid membrane. Now, aldosterone is coming into the cell. And what it is doing? Aldosterone, it will go and bind with its receptor. Aldosterone is binding with its receptor. Now, what will happen at the end of the day? This aldosterone and its receptor complex, it will enter into the nucleus. It will act on the DNA, helps in transcription will happen, translation will happen at the end of the day. What is the effect of aldosterone? Sir, because of the transcription and the translation, new proteins are synthesized. New proteins are implanted for the first time now. For the first time, now new proteins are implanted over here. Now, what are these proteins? These are channels, water channels. Sorry, they are not water channels. These new proteins are called as epithelial sodium channels, ENaC. They are called as ENaC, epithelial sodium channels. Now, what these epithelial sodium channels are doing? The name itself is there. They are present on the epithelial cells. They are sodium channels. So, now sodium is getting reabsorbed. So, sodium reabsorption is happening. Okay, sodium reabsorption is happening. Aldosterone acting on the principal cells, sodium reabsorption happening. Now, see, positive ions are entering into the cell. Extra positive ions under the influence of aldosterone is entering into the cell. Now, if more and more positive ions comes into the cell, the electrophysiology will be affected. Now, what will happen if one sodium ion, if it comes into the cell, one positive ion will go out of the cell. If one sodium comes into the cell, one positive ion will leave out of the cell. So, what is this positive ion leaking out? Potassium. So, from this we can simply say aldosterone helps in sodium reabsorption, but aldosterone will cause potassium excretion. By acting on which cell? By acting on principal cell. Aldosterone having which receptors? Self-surface receptors or cytoplasmic receptors? Aldosterone is having cytoplasmic receptors. Aldosterone is a steroid. It will cross the cell membrane. Okay. Now, which channels are implanted under the influence of aldosterone? epithelial sodium channels called as ENaC, epithelial sodium channels. Never ever say, see, most of the students will confuse here. Most of the students, if I ask them what is the function of aldosterone, they will say, sir, aldosterone helps in water reabsorption. No, sodium reabsorption. Aldosterone is a mineralocorticoid, helps in reabsorption of which mineral? Sodium. So sodium is getting reabsorbed. Along with the sodium, water will also be reabsorbed, no doubt. First main priority is sodium reabsorption. Along with the sodium, some amount of water will also be reabsorbed. Okay, so aldosterone function is sodium reabsorption. Completed, sir. Now let's talk about what is the action of aldosterone on intercalated cell. Now whenever aldosterone acts on intercalated cell, do you know what will happen? Now aldosterone will bring the changes in such a way, now intercalated cells, they are excreting protons out. So proton excretion, protons are excreted out. Now from this you should tell me what are the functions of aldosterone. First of all, first question, aldosterone is acting on which cells? Acting on principal cells. It's acting on principal cells as well as intercalated cells. It's acting on both principal cells as well as intercalated cells. Okay. Now if it act on principal cells, what are the three important functions? The main important function is sodium reabsorption. When sodium is reabsorbed from the epithelial sodium channels, little amount of water will also be reabsorbed. When sodium positive ions are getting into the cell, in order to maintain the electron neutrality, potassium is going to leak out, potassium is excreted. So aldosterone is causing sodium reabsorption, water reabsorption, but potassium excretion. Okay, and when aldosterone, when it acts on this alpha intercalated cells, intercalated cells will help, will cause proton, H plus means protons, protons are the acid excretion. Okay, acid excretion. Now you know all the important functions of aldosterone. Now I am telling you one, one disease. Let's have a pathocorrelation. Okay, the pathocorrelation is that there was this one disease which is called as, see, this is the adrenal gland. Okay, adrenal gland. Now in the zona glomerulosa, there is this one adenoma present. Adenoma means a tumor, a mass is there. Now what this mass is doing, it is producing excessive amount of aldosterone. Excessive amount of aldosterone is there. Now then, can you name me what is the name of this disease? Can you name me what is the name of the syndrome? The syndrome where there is the adrenal adenoma which is producing excessive amount of mineralocorticoids. Adrenal adenoma producing excessive amounts of mineralocorticoids, excessive amount of aldosterone. Can you name me the name of that condition? What is the name of this condition, guys? Excessive aldosterone excretion production is happening. It starts with the letter C. Conn's syndrome. So Conn's syndrome. So what exactly is Conn's syndrome? Conn's syndrome is the adrenal adenoma, adrenal tumor producing excessive amount of aldosterone. Now in Conn's syndrome, you have to tell me the features. Now what are the features which are present in the Conn's syndrome? There is excessive amount of aldosterone. Whenever there is excessive amount of aldosterone, what will happen to sodium? Sodium, more and more sodium is getting reabsorbed. If more sodium is reabsorbed, the person will have hypernatremia. Okay, see, initially there will be hypernatremia, later the sodium levels will become normal because of something called as aldosterone escape phenomena. But as of now, just as you are we are discussing about the basics, simple. When the person is suffering with Conn's syndrome, he is having excessive amounts of aldosterone. Now we all know aldosterone helps in sodium reabsorption. So whenever there is excessive amounts of aldosterone, this excessive amount of aldosterone will reabsorb more amount of sodium into the body. So that will cause hypernatremia. The person is suffering with now hypernatremia. Now the same aldosterone is excreting the protons, excreting the potassium. So more potassium is excreting out of the body. If more potassium is excreting out of the body, so potassium loss, potassium is losing out, that causes hypokalemia. It causes hypokalemia. And even protons are losing out of the body. If protons are losing out of the body, so acids, protons are acids. You are losing the acids out of the body. So that will cause acidosis or alkalosis. You are losing the acids out of the body. Acids are going out. So you will suffer with acidosis or alkalosis. So a patient with Conn syndrome, he will suffer with acidosis or alkalosis. Now tell me, he will suffer with alkalosis. Okay, so a patient who is having Conn syndrome, he will be having hypernatremia. Because of hypernatremia, more sodium, even the person will suffer with hypertension. Hypernatremia, hypertension will be there, hypokalemia will be there, as well as metabolic alkalosis will be there because of proton excretion. So this is a very important point which you need to know regarding Conn syndrome. Okay, now how to treat this Conn syndrome? Pharmacorrelation. Now, what are the drugs which can be used to treat Conn syndrome? In Conn syndrome, the main problem is excessive amount of aldosterone. Excessive amount of aldosterone, the main problem. Now, what we should do? We should give aldosterone antags. Okay, aldosterone antagonists or aldosterone receptor blockers. See, there are drugs which will go and inhibit the aldosterone receptors. So aldosterone is there, but it cannot go and bind with the receptors. So can you name me any aldosterone antagonist drug which is used in the treatment of Conn syndrome? Can you name me? Aldosterone receptor blockers or aldosterone antagonists. One drug, very important drug, kept on coming in the exams. The name of the drug, it will start with the letter S. P, I, Sp. Spirono or Spirono lactone. So what kind of drug is spironolactone? Spironolactone is aldosterone antagonist. Okay, now a very very important point. Lot of time this question was asked in the exam. Can you name me one of the side effect of spironolactone? If a person is using spironolactone, he will suffer with, okay, especially males. What is the side effect of spironolactone? Not sartan. Someone is saying sartan, the telmisartan, candisartan. Those are something totally different drugs. Okay, olmesartan, telmisartan, candisartan, those are ACE inhibitors. Those are ACE inhibitors. Right now I am talking about aldosterone antagonist. Okay. Can you name me? It's a spironolactone. Side effect is gynecomastia. Okay, gynecomastia. Breast development in males, gynecomastia. Okay, now this is a very important area even from the pharmacology. Why? Because there are a group of drugs. There are a group of drugs which will cause gynecomastia. So just as a pharmacological correlation, I am just giving the drugs which will cause gynecomastia. The very famous mnemonic is DISCO group of drugs. DISCO group of drugs. D for digitalis, I for isoniazid. Okay. S for spironolactone, C for cimetidine, and O for estrogens. So these are the drugs. So distal is isoniazid, spironolactone, cimetidine, and estrogens. Now these drugs are the ones which are having a side effect of gynecomastia. So spironolactone is a drug which is used in the treatment of Conn's syndrome. Okay, now let me discuss about one more important disease. Okay, based on the concept whatever we have studied, let me discuss about one more important disease. If you know the name of the disease, you just put it in the comment box. Again, I am showing you the collecting ducts here. Now the first cell which I am showing you is principal cell, sir. Okay, the name of the cell is principal cell. Here these are the channels which are present over here. Okay, these are the channels. Now aldosterone is coming. Aldosterone will come and will help in the production of these channels. Now from these channels, sodium is getting reabsorbed back into the body. Sodium is getting reabsorbed. Okay, sodium is getting reabsorbed. Now important point here is, sir, what is the name of this channel? Can you tell me? What is the name of this channel? The name of the channel is ENaC, epithelial sodium channel. Now my question is, Epithelial sodium channels are under the control of which hormone? So whenever there is aldosterone, these epithelial sodium channels are produced. They will help in reabsorption of sodium. Now whenever the aldosterone concentration goes down, or whenever the aldosterone half-life is completed, whenever there is no aldosterone, what will happen? Even this epithelial sodium channels will be degraded. They will be automatically degraded. Okay, so whenever there is aldosterone, sodium reabsorption will happen. Whenever there is no aldosterone, the sodium channels will be destroyed, so that there is no sodium reabsorption. Now, what I am saying, at the end of the day, sodium reabsorption is under the total control of aldosterone with the help of epithelial sodium channels. Or I can also say epithelial sodium channels are functioning under the influence of aldosterone. But there was this one disease which is called as, or you should tell me the name of the disease. See, there is no aldosterone. Okay, aldosterone is not there. Okay, aldosterone is not there. But still these epithelial sodium channels, they are over functioning. They are kept on functioning. They are kept on reabsorbing the sodium into the body. Okay, they are kept on reabsorbing the sodium. So there is excessive sodium reabsorption is happening. Can you name me the name of the syndrome? Guys, can you name me the name of the syndrome? What is the syndrome where there is excessive functioning of epithelial sodium channels? ENaCs. Can anyone? Isha, Saitej, Tom, Ranjan. Do you guys know what is the name of this disease where there is excessive functioning of the epithelial sodium channels? They are continuously functioning. Even though there is no aldosterone, they are kept on functioning because of certain mutations. This syndrome is called as Liddle syndrome. Okay, Liddle syndrome. Now in Liddle syndrome, there is excessive functioning of the epithelial sodium channels. Now tell me, as a good doctor, you should tell me, as a good doctor, how you are going to treat this condition? Liddle syndrome is treated by. How you should treat the Liddle syndrome? Think logically. Liddle syndrome, see, first of all, there is no aldosterone. You don't need to give the spironolactone. There is no aldosterone. Aldosterone is given in conditions like the one which we have discussed previously. Aldosterone receptor blocker is given in adrenal adenoma, where there is more and more aldosterone, the Conn syndrome. Right now there is no aldosterone. So what you have to do? Saitej, that's what I am saying. There is no need of spironolactone. First of all, aldosterone itself is not there. Even without aldosterone, these epithelial sodium channels are over functioning. So what you have to do? Where is the problem? Epithelial sodium channels, they are over functioning. So what you should do? You need to block this epithelial sodium channels. Okay, you need to block this epithelial sodium channels. Okay, if you are not blocking, means excessive amount of sodium is getting reabsorbed. Now this excessive amount of sodium will cause hypernatremia, and that will cause hypertension. More sodium means more salt in the body. More salt in the body means hypertension. Okay, so how to block these drugs? How to block these channels? Can you name me? Epithelial sodium channel blockers. ENaC, epithelial sodium channel blockers are the ones which is used in the treatment of Liddle syndrome. The name of the drugs are amiloride. Okay, amiloride and tramterine. Okay, amiloride and tramterine. So what are the drugs? What are these drugs? What is the mechanism of these drugs? Amiloride and tramterine. These are epithelial sodium channel blockers. Okay. Now, after this, let's discuss about the second hormone. Guys, what are we discussing? We are discussing about the collecting ducts. Now, I have taught you in the beginning of the lecture. See, there are two important hormones which are acting. Aldosterone is acting on the collecting ducts. It's acting on the principal cells. It's acting on the intercalated cells. We have discussed all the important points regarding the aldosterone. Now, we are left with the points of antidiuretic hormone. What antidiuretic hormone is doing? From where it is coming? It's helping in what? We'll discuss now. Okay. If you have any doubts, you can ask me in the comment section. Now, we have to discuss about antidiuretic hormone. Okay, antidiuretic hormone. Guys, do you have any doubts? Is it clear? Are you guys getting the concept? Like, if you feel like I'm going a bit fast, you can all the time, give me the, you can all the time give me the, feedback in the comment section. Sir, you are going a bit fast, try to be little slow. Okay, I will try to, do, accordingly. Antidiuretic hormone. First question is, from where antidiuretic hormone is produced? My question to you. Antidiuretic hormone called as ADH or vasopressin. Antidiuretic hormone or vasopressin is produced from where? Anyone? Ranjan, Isha, Real, Tube, Saitej, Tom, Harini. Tell me, from where the antidiuretic hormone is produced? If you are really good, tell me. From where antidiuretic hormone is produced? Any idea? Which part of your body is producing the antidiuretic hormone? Adrenal gland. Adrenal gland is producing aldosterone. Never confuse. Aldosterone is coming from adrenal gland. Aldosterone, cortisol, sex corticoids, adrenaline are coming from adrenal gland, not antidiuretic hormone. Okay. Someone is saying, Tom Cruise is saying posterior pituitary. You are wrong. You are wrong, Tom. Antidiuretic hormone is produced from the hypothalamus. Okay, imagine this is the hypothalamus. Okay, in hypothalamus there is this one nucleus. There is one nucleus called as supraoptic nucleus. Supraoptic nucleus. Now the supraoptic nucleus is producing the antidiuretic hormone. Now from the supraoptic nucleus, antidiuretic hormone is coming to where? It's coming to posterior pituitary. Okay, now hypothalamus is producing the antidiuretic hormone from which nucleus? Supraoptic nucleus. Now the antidiuretic hormone is coming and getting stored where? In the posterior pituitary. Okay, here is your antidiuretic hormone. Now let's take about a scenario. Okay, let's take about an example where you guys have been to a trip to Africa. You have gone to Sahara Desert. Okay, now unfortunately you got separated from your your friends. You got separated from your group. Now you are alone in the middle of the desert. You are alone in the middle of the desert. Now for entire day you are just going on like that. Okay, you are just searching for your friends. You are not getting any you are not seeing any of your friends. You are not having any water to drink. Now in that hot arid climate you are losing water from your body, so you are getting dehydrated. Now is that a good time to produce urine? Is that a good time to lose water from your body in the form of urine? Now whenever you got separated, whenever you are lost in the desert, whenever you are getting dehydrated, is that a good time to produce urine? Is that a good time to lose excessive water from the body? I'm asking you. No, that's not a good time. You have to conserve as much as water as possible. So what your body will do, your body will produce a hormone which is called as antidiuretic hormone. Now your hypothalamus is producing antidiuretic hormone. Now this antidiuretic hormone is actually stored in the posterior pituitary. So whenever your body is getting dehydrated, whenever you are dehydrating, your plasma osmolarity will be increased. Your blood is getting concentrated. You are losing water from your body in the form of sweat. So your blood is getting concentrated. Your blood is becoming hyperosmolar. So now in this condition, the posterior pituitary, now from the posterior pituitary, antidiuretic hormone is released. Now what this antidiuretic hormone should have to do? Now antidiuretic hormone should have to do antidiuresis. Antidiuresis means it have to decrease the amount of urine which was supposed to be produced. Now the antidiuretic hormone, now see what it will do. Now let's again come back to our concept. This is your collecting duct. Now we all know on the collecting duct which cells are there? Principal cells are there. Okay, principal cells. Guys, never forget principal cells. A lot of times this question was asked. Principal cells are present where? Collecting ducts. And even principal cells are also present on the late distal convoluted tubule. Okay, even on the DCT and collecting tubules, these principal cells are there. No doubt. Now, our hormone to be discussed is antidiuretic hormone. I am again repeating. Never confuse antidiuretic hormone with aldosterone. Aldosterone is a mineralocorticoid, helps in sodium reabsorption, which is coming from zona glomerulosa of adrenal gland. Right now we are discussing about antidiuretic hormone which was produced in a person who is getting dehydrated. Now this antidiuretic hormone, it is coming and acting on the principal cells. Now this antidiuretic hormone, it have a receptor on the cell surface. Okay, there was this one receptor. Now what is the name of this receptor? The name of this receptor is V2 receptor. V2. Okay, V2 receptor. Now whenever the antidiuretic hormone is acting on the V2 receptors, do you know what happens? At the end of the day, I am telling you, at the end of the day, a new channels are produced. Don't confuse, these are not epithelial sodium channels. Epithelial sodium channels are different. They help in sodium reabsorption. But these channels right now are the water channels, newly produced. Do you know name of the name of these channels? These channels are called as aquaporin 2, not 1. See, in the descending limb of loop of Henle we have discussed. In the descending limb of loop of Henle there are aquaporin 1 channels. Right now I am talking about aquaporin 2 channels. Remember, in collecting ducts, water reabsorption will not happen. Normally, in you and me, normally the collecting ducts are impermeable to water. No water reabsorption is happening. Only under the influence of antidiuretic hormone, now this aquaporin 2 channels are produced. Now this aquaporin 2 channels will start to reabsorb water. So now what's happening? Water is getting reabsorbed back into the body. So water loss is now getting minimal. Water loss is not happening. All the water is getting reabsorbed back. There is no water loss. Okay, water is not losing, and that's what we want. That's what we want now. Okay, so now tell me, collecting ducts are permeable to water, impermeable to water? They are impermeable to water normally. Water reabsorption in collecting duct depends on, see, water reabsorption reabsorption of water in collecting ducts is which type of water reabsorption? Is it obligatory water reabsorption? No. Water reabsorption in collecting ducts is an example of facultative water reabsorption. Okay, facultative water reabsorption. What does I mean by facultative reabsorption? So only under the influence of antidiuretic hormone. If there is antidiuretic hormone, water reabsorption will be there. If there is no antidiuretic hormone, there are no aquaporin 2 channels, water reabsorption cannot happen. So water reabsorption is dependent on a hormone. So that's called as facultative water reabsorption. But when I am discussing in the PCT, proximal convoluted tubule, and descending limb of lip of Henle, there also water reabsorption is happening. But there is no hormonal influence. No hormonal influence. So there it is obligatory water reabsorption. But here it is facultative water reabsorption. So direct question in your exam. Facultative water reabsorption happens in which part of the nephron? Collecting ducts. Facultative water reabsorption is dependent on which hormone? Antidiuretic hormone. Okay, facultative water reabsorption is happening via which channels? Aquaporin 2 channels. Aquaporin 2 channels. Okay. Now, after discussing this, see the amount of, see even this water, see some person like, Tom, what you are asking is this water, will it affect, you are asking, will it affect medullary hyperosmolarity? No. Why? Because vasa recta is there. No. Vasa recta will again take this water also. Even vasa recta will take this water and take the water again back into the systemic circulation. So medullary hyperosmolarity is not affected because of vasa recta. Okay. Now if you Understand this concept. Okay, now two important diseases we will discuss. We will discuss two important diseases. 100% out of these two diseases, one question will be there in your exam. Whether you are giving FMG exam or whether you are giving NEET PG exam, this question is for sure. Now, the first disease which we will discuss is called as diabetes insipidus. Okay, diabetes insipidus. Diabetes insipidus. Now, what is this diabetes insipidus? Don't confuse it with diabetes mellitus. Diabetes mellitus is something because of no insulin, hyperglycemic states. You all know it. Right now, what I am discussing is diabetes insipidus. Now, what is the problem in diabetes insipidus, sir? Sir, in diabetes insipidus, the patient is suffering with no antidiuretic hormone. Antidiuretic hormone is not there. So, it's a no antidiuretic hormone. Antidiuretic hormone is not getting produced. Okay. Now, whenever there is no antidiuretic hormone, what will happen? Let's see. Again, collecting duct, sir. Collecting duct. Here are your principal cells. Whenever the antidiuretic hormone, whenever it's not there, now can V2 receptors are stimulated? Can V2 receptors are stimulated? No, V2 receptors cannot be stimulated. If V2 receptors are not stimulated means, can this aquaporin 2 channels will be there here? Aquaporin 2 channels are not going to be there. Aquaporin 2 channels are not functioning. When aquaporin 2 channels are not there, means what happened? Now water is freely lost in the urine. Water is lost in the urine. Now this person is producing more urine or less urine? Just tell me. Now if a person is not having antidiuretic hormone, see usually in you and me, like there will be some amount of antidiuretic hormone. Okay, a little amount of antidiuretic hormone activity will be there physiologically in you and me also. So with the help of that antidiuretic hormone, little amount of water reabsorption will happen. Not much, but little amount of the water reabsorption is happening. But if completely there is no antidiuretic hormone, what will happen? Now water is getting into the urine. Now this person, he will have more urination or less urination? He is going to have more urine production, more urination. That will cause diuresis. Diuresis means more and more urine he is producing. He is producing a tremendous quantity of urine, lots and lots of urine. Now, every time, 15 minutes, 20 minutes he is going for urine. Okay, now this is not something good, right? This is not something good with the quality of life. Okay, now even during night he is producing more urine and he is having an urge for going to the urination, washroom. Now, as a good doctor who is listening this lecture, you tell me how to treat this condition. The person is not having antidiuretic hormone. Now, how you can treat this condition? Just tell me. He is having more urination. Every half an hour, every 1 hour he is rushing to the washroom. How you can treat? If he is going to the washroom so many times, polyuria, his quality of life will be affected. He will suffer with dehydration. Lot of electrolyte imbalances will happen. Now, how to treat this condition? Tell me. Simple, very simple. Isha, Tom, Ranjan, please. Naveen, you can tell. ADH should be given. Very simple, right? The ADH is not there, but you cannot make ADH outside, right? In the pharmaceutical industries, you cannot make the ADH out, ADH. So, you can make a drug which is similar to ADH. Antidiuretic hormone is also called as vasopressin. We all know antidiuretic hormone is also called as vasopressin. So, we have made a similar drug in the pharmaceutical industry which is called as desmopressin. Now, desmopressin is nothing but an analog. It just looks like vasopressin. So, whenever you give desmopressin, inhalational route, it will have to be taken via inhalation. So, this desmopressin will come and activate V2 receptors. Now, whenever you stimulate the V2 receptors, automatically aquaporin 2 channels will start to function. They will start to reabsorb water and the amount of urine production is going to be decreased. So, now tell me, what is the drug of choice? Now, what is the drug of choice for diabetes insipidus? The drug of choice for diabetes insipidus is taking a desmopressin via inhalational route. Okay. Now, let's talk about one more condition. Now, you have to tell me, again I am drawing you here the collecting ducts. Here is your principal cell. Now, what I am saying is, see, now this red color dots are nothing but antidiuretic hormone. Okay. Now, in this condition, what is the problem? You should tell me. Okay. Here is your V2 receptor. Now what is the problem in this condition? Tell me guys. What's happening? Now I am showing you, I am putting one condition towards you. Tell me. Now here there is excessive amount of antidiuretic hormone. The person is producing excessive amount of antidiuretic hormone. Now you may get it out, sir, why unnecessarily patient is getting producing excessive amount of antidiuretic hormone? I just want you to know there is one important cancer called as small cell carcinoma. Small cell carcinoma, CA for carcinoma, cancer, small cell carcinoma of lung. It's a lung cancer, very dangerous type of lung cancer, which is also called as oat cell cancer, oat cell cancer of the lung. Now this lung cancer, it's a cancer, right? Now this cancerous cells, they can produce any type of hormone. Actually this lung cancer, the small cell cancer or the oat cell cancer, it can produce any type of hormone. Now this lung cancer unnecessarily in the body, it is producing excessive amount of antidiuretic hormone. So much amount of antidiuretic hormone is there. Now tell me, whenever there is excessive amount of antidiuretic hormone, this V2 receptor is excessively stimulated. When you stimulate the excessively this V2 receptor, what will happen to water reabsorption? Excessive amount of water reabsorption will happen. Now excessive, too much water reabsorption. Okay, too much amount of water reabsorption is happening. Now tell me, what kind of urine he is going to produce? He is going to produce concentrated urine or diluted urine. Now, because of the excessive antidiuretic hormone, so much amount of water is being reabsorbed. So what happened to urine status? Urine is going to be concentrated or urine is going to be diluted. Now tell me guys, there is less urine production, or I should say concentrated urine. Water is reabsorbed, right? All the water is reabsorbed. So urine is getting concentrated. Okay. Now he is producing hyper concentrated urine, hypertonic urine he is producing. Now he is not he is not producing enough amount of urine. That is again bad. That's again definitely bad. Now how to treat this condition? Tell me. If you tell this condition, you are awesome. How to treat this condition, sir? Now what is the treatment for this condition where the person is producing excessive amount of antidiuretic hormone? First of all, wait, let me tell the name of the syndrome. The name of this disease is called as SIADH. SIADH. What is SIADH? Syndrome of inappropriate antidiuretic hormone synthesis. Syndrome of inappropriately antidiuretic hormone is getting synthesized. If you feel it little difficult, just know it like this: syndrome of increased antidiuretic hormone, syndrome of increased ADH, syndrome of increased ADH. Now how to treat this condition? Tell me. ACE inhibitors. Malik, you are saying ACE inhibitors. Why ACE inhibitors? Why do you want to give ACE inhibitors? You want to simple. Sir, here the problem is excessive ADH. Let the ADH be there. Okay, let the ADH be there. See, what you can do here is you can block this receptor. Very simple. If you block the V2 receptors, this receptor I have already taught you. The ADH receptor is a V2 receptor. If you can block this V2 receptor, ADH cannot do anything. ADH cannot do anything. So V2 blockers. So V2 blockers are the drug of choice for SIADH. V2 blockers are drug of choice for SIADH. Can you name me any V2 blocker? Can you name me any V2 blocker? Guys, anyone knows V2 blockers? I'm asking you. See, PK, you are saying fluid restriction. Already. Yeah. I understood. What do you mean by, see, he is reabsorbing very so much amount of water. Yes, you are absolutely true. What will happen is, if lots of, what he is trying to say in the comment section is, if lots and lots of water is reabsorbed, now there is no need for to take excessive amount of water. So fluid restriction. And sodium chloride supplementation. Why? Because all this water, whatever is reabsorbed, it causes dilutional hyponatremia. In detail you will study in internal medicine. Right now in physiology there is no need to go in that depth. So what I am asking is, what is the Drug of choice, V2 blockers. Can you name me any drugs? Vaptons. Okay, Vaptons. Okay, what are these Vaptons? Conivaptan. Okay, Conivaptan, Tolvaptan. So Conivaptan, Tolvaptan, they are V2 receptor blockers. They block the V2 receptor. So ADH cannot work. So you can treat SIADH, syndrome of inappropriate antidiuretic hormone synthesis. Now with this, we have discussed important points, like important points and important pathology also. Okay, important pathological points also. Okay, now in the next 5 minutes, okay, we'll discuss for the next 5 minutes and we will end this session. Okay, next 5 minutes we'll end this session. Why? Because if I teach acid base balance in this class itself, it will be too much hard for you. Okay, so continuously listening a lecture will be a bit more hard for you. As you are beginners, it will be a little hard for you. So let's discuss a few more important points. Let's see some pathological and pharmacological correlations which are very important for your exam and end this session. Okay, now receptors for antidiuretic hormone. Receptors for antidiuretic hormone. See, I have already taught you one important receptor which is V2 receptor. The V2 receptor is present where? On the collecting ducts, I have taught you. But remember, there is one more important receptor called as V1 receptor. The antidiuretic hormone is also called as vasopressin, sir. Vasopressin. It presses the blood vessel. Vasopressin means it presses the blood vessels, meaning it causes vasoconstriction. Vasoconstriction. So, V1 receptors are present on blood vessels. Okay, where V2 receptors are present? V2 receptors are present on nephrons, collecting ducts. Okay, collecting ducts. Where V1 receptors are present? V1 receptors are present on blood vessels. Okay, V1 receptors are present on blood vessels. For example, see, when you stimulate V1 receptor, what will happen? There will be vasoconstriction. If you stimulate V2 receptor, what will happen? There will be water reabsorption, which we have already discussed. Now, what is the important pathological correlation? What is the important pathological correlation? See, there is one disease where there is abnormal dilatation of veins in your esophagus. There is this one disease where there is abnormal dilatation of veins. Veins means blood vessels. Abnormally, veins are dilated. See, I am just showing you the esophagus. Imagine this is the esophagus. Now, inside the esophagus, abnormally, the veins are dilated. The veins are tortuous. Okay, the veins are abnormally dilated. Actually, whenever the patient is having liver failure, whenever the patient is having cirrhosis and liver failure, that will cause portal hypertension and that will lead to this condition, abnormal dilatation of veins in your esophagus. Can you name me this condition? If the veins in your esophagus are abnormally dilated, can you name me this condition? It's called as esophageal varices. Esophageal varices, abnormal dilation of the blood vessels in the esophagus. Now, as a good doctor, what you should do? If abnormally the veins are dilated, whenever you are eating, such a dilated, tortuous veins can be destroyed, will cause bleeding, GI bleeding. What you have to do? You have to constrict those blood vessels. Okay, so in esophageal varices, what you should do as a good doctor? You should cause constriction of the blood vessels. You should make the blood vessels to go back to their normal patency. So what you should do? We know on the blood vessels there is V1 receptor. If you can stimulate this V1 receptor, that will cause vasoconstriction. So here in the condition of esophageal varices, what you need? You need vasoconstriction. So treatment is vasoconstriction. So what you should do? You should stimulate V1 receptor. So what is the drug? Normally V1 receptor, V2 receptors are stimulated by antidiuretic hormone. V1, V2, they are the receptors of antidiuretic hormone. But we can't have antidiuretic hormone outside the body. So there is a drug called as terlipressin. Okay, so terlipressin is the V1 receptor stimulant. Which is the drug of choice for treating esophageal varices. Okay, so esophageal varices are treated with the drug called as terlipressin, which is a V1 agonist. okay, which is a V1 agonist used in the treatment of esophageal varices. Okay, hope you have understood the concepts. In the next lecture, okay, in the next lecture we will discuss about a micturition and acid base balance. Hope the lecture is helpful. If you find the lecture helpful, please give us your feedback. Okay, see you in your next class. Thank you.